Welcome to our fourth and final installment of the webinar series entitled Medicare's New Conditions of Participation. Are you in compliance? Today's session will focus on emergency preparedness, compliance, and the clinical record. It's my pleasure to introduce today's speaker. Sharon Litwin is founder and senior managing partner at 5-Star Consultants. 5-Star Consultants is a national consulting and coding firm specializing in home care and hospice services since 2003. Sharon is a former ACHC and CHAP surveyor, performing Medicare deemed surveys for 10 years. Sharon has been in the home care and hospice industry for over 25 years. In her consulting firm, Sharon assists home care and hospice agencies in improving quality, meeting regulations, ICD-10 coding, OASIS, increasing outcomes and star ratings, and having continued survey readiness. Sharon and her staff perform ICD-10 coding and OASIS reviews, CoP, clinical record reviews, mock surveys, and help agencies across the country stay in compliance. Sharon is a regular speaker to education companies, state and national associations, and publications. With that, I turn it over to you, Sharon.
Thanks, Monica. And thanks, everybody, for joining us again for part 4 of our presentation on our new COPs. So as Monica said, we'll do emergency preparedness, the compliance with federal, state, local laws and regs, and clinical records. Even though clinical records is last, it's a big one. Well, I probably could cut this session real short for you and say you have some free time because, of course, everybody is in full compliance of the emergency preparedness COP, right? Because it's been in effect since November 15th. Well, I'm sure that you're rolling your eyes or chuckling or shaking in your boots because don't worry, you're not alone. There are many, many, many agencies that are just getting going on it. One of my long-term clients that, we had been working with all along, and I thought that they would be, excellent with this, especially from what they had told me, and I was at their agency on Monday, and I was a little disappointed, though I didn't show it, I hope, but, they had it all on paper, but, did they call their staff? Did they actually do a drill? Did they do a critique of it? Did they call the patients and see who they couldn't contact? No, none of that was done. So just having, the plan, the communication plan and the policies and the training plan on paper and not implementing it is not where you have to be by now. So like them, if that's where you are, we will talk about what you have to do now. So this is a final rule that was for, pretty much all of healthcare in September of 16. It actually went into implementation November of 16, but you know how much we've had going on with home health, and so don't feel bad again if you didn't get started then, because I'm a consultant and we didn't pay attention to it at first because of value-based purchasing and on and on and on. So anyhow, you are expected to have had it totally effective November 15th, but if you haven't, hey, the sooner the better. So it is 17 provider types in healthcare, which includes home health and hospice. And, the big thing is you have to comply with all federal, state, and local emergency preparedness requirements. So, anything that you have in your county, and certainly for the state, but also, what are the local requirements? You have to get hooked in with your local EMS system, whoever is over that for your area, because that does change across the country. Never a better example to talk about this today than after the horrific disaster, emergency that happened in your state just yesterday at the school. And I heard over and over on the news, I was driving quite a long way, so I was listening to it on the radio, and I heard over and over of how prepared the school was, that morning they actually had a fire drill, but that they have done these disaster emergency lockdown plans, obviously a little different than healthcare, but not too much so when you're talking about schools. And they were very, very prepared. If they hadn't been so prepared, wow, I could have been much more horrific than it even was. And so when you're looking at this as being busy work, you guys have lived through a lot this year, the horrible hurricane. I talked to a new client that we started about just over a month ago, and they're in Florida, and they had to move their office 3 times after the hurricane, and they still were having problems getting into their EMR and just so many other difficulties. So think of this not just as busy work you have to do to stay in compliance, but as absolutely helping you to be ready for whenever the next bad thing happens, because it isn't if, it's when. And we all know that that's both man-made and natural disasters. I think that the agencies that can live and breathe it and say that's what we're doing, we're really being in preparation, are the ones I see being in compliance as well. So the standards for us, the elements when it was the big COP for all of healthcare, our emergency plan, policies and procedures, communication plan, and training and testing program. That's the biggie that a lot of agencies are not in compliance with yet. So the emergency plan, there's a lot of redundancy in this COP, as I've said with so many of the other ones like patient rights. So within these 4 standards, you'll hear them repeat the same things over and over again, but you're just doing a different part of the plan at that point. So you have to develop and maintain an emergency preparedness plan that must be reviewed and updated at least annually. Keep in mind with this that you will be updating it more than annually, because if you're doing 2 drills a year, you are going to be critiquing those, and you're always going to find areas that you need to improve on. And so that's when you go back and you revise the plan. The plan has to do all of the following. It has to be based on and include a documented facility-based and community-based risk assessment utilizing an all hazards approach. All hazards does include cybersecurity. I am blown away time and time again that agencies aren't putting in the plan and then testing and having backup for when their EMR goes down. If we have no power, you have no EMR. And particularly like the clients that I was working with this week, they're still server-based. They're not on the cloud. And so all their information is sitting right there in that server in their agency. So you have to have backup. And we'll talk more about cybersecurity in a little bit. The best thing to do if you haven't done a full risk assessment is to get with your county, or like I said, if it's more local than that, a lot of times it is the county, but you have big counties, so maybe it is more local than that, and get their risk assessment. A lot of agencies have been real successful with that. Now, some that I've seen that have gotten those, it's great. It's 20 pages. It's very, full of all types of scenarios that could happen, but it's not customized to your agency. So you even have to take it further down the line and customize it for your agency. Everything in this plan, you have to keep that in mind, that you have to make it yours. So in other words, you're in one of the agencies that I started up and had worked with for a long time. Although they were part of a big, very nice hospital system, the building and the area that they had the home health in was not desirable by any means. And it was in a basement. It had an exit, going to the outside, so that's why they put them in it. But it was old and musty and I'm sure moldy, and it flooded a lot. And so the county certainly isn't going to have something specific like that, because that was flooding when there weren't overall floods in the area. And so you have to specify it to what your situation is. And I'm in enough agencies that I see there's that type of thing in a lot of them that I go to. Unfortunately, we don't always have for home health the most top-rated office buildings around. All right. So now you do that risk assessment, and that's where a lot of agencies stop. Well, now you have to do what are your strategies to address emergency events identified by the risk assessment. That takes a lot longer to do than just putting the risks down. And so if you don't address what you're going to do for them, what is the good of doing a risk assessment? All right. Part of your specification has to be addressing your patient population. I just have talked to an agency this week that they have to be Medicare certified in their state, unfortunately, because all they do is Medicaid pediatrics, and it's a program for the long term, but because of how their state is set up, they have to be Medicare following the COPs, even though this is a Medicaid waiver program. And so their patient population is very different than the norm of what's out there in home care. It's very much more like a private duty with long-term vent kids primarily. So whatever your patient population is, if you do a lot of IVs, if you have a lot of non-ambulatory patients, so that has to be in place. And now you have to say what you have the ability to provide for this patient population in emergency situations. What is your continuity of operations? We're going to talk a lot later about the new normal. I'm afraid because of the hurricane and other things that have occurred, I'm sure none of you in the area of Broward County where this disaster was yesterday are even on the call, but you might listen to it ultimately. Well, you're going to have to look at a new normal and say, what are we going to do in those events? So the delegations of authority and succession plan, so we were meeting with the emergency planner for this agency, and they're part of a system. And so she comes down to this meeting and has a big binder and has stuff in it. But the home health director is sitting right there, and the home health administrator is the one that, assigns this emergency preparedness person for the system to do this. They did not have this manual that she has. They don't have the list of the phone numbers. They don't have designated people in their agency that live in different geographic territories having the information. You have to have that in place because maybe, and as I was talking to them, 2 of the 3 of them lived in the same area down the street from each other. So if some disaster happens, it's more likely that you need to have someone in a different territory have that information as well, so that you are ensured that you have access to your staff and the emergency authorities and your patients and the physicians. No matter what's happening with your agency, somebody is available to get that. And you can't say it's just on a file on the computer. I was saying to them, we do have to go old school and, carrying our big on-call books that we used to do. You have to do some parts of that in this world today to get ready for an emergency, because we're so fragile, because so much relies on electric, and electric, as you well know, can be out for a long time. Well, are those EMR systems going to be working? You have to include cooperation and collaboration with local, tribal, regional, state, and federal emergency preparedness officials to maintain an integrated response, including all documentation of your efforts to contact the officials, and when applicable, how did you participate and collaborate and also cooperate in their planning efforts. So you're a part of this, and it's not as hard today as it was in the past, because most healthcare entities have to do this. So as you call your local emergency preparedness officials, they're used to hearing from healthcare entities in our industry. So they kind of have, for the most part, a plan in place for how to include everybody and what they're going to tell you and give you. So the cybersecurity, this isn't in our COP specifically, but it was a memo that came out to the state survey departments from CMS last year. And I still haven't seen, maybe it has been released to all of you. I haven't seen that. But it's saying how important it is to have that all hazards include a cyber attack, as well as my example of in a, natural disaster when the electric is down too long. But your policies and procedures have to, if you have whoever is the designated IT director, include timeline for system shutdown, timeline to report to state and federal agencies and state health departments, and alternate communication plans. How else do you access and complete your clinical records? Well, certainly the accessibility is difficult if you are server-based. If you are cloud-based, that accessibility will not be as difficult. So if you do have a server, you're going to have to do more methods to access clinical records. And then you have to include that cybersecurity in your initial and annual training, and you have to include it in your annual training exercise. So that's all areas that CMS said to the state survey departments they're to be looking at. All right, so the policies and procedures, you can take this like we did in our company for our policy manuals and make a good policy and procedure from this. But like I said, this is only a tiny piece of it. So the policies and procedures are based on the plan, the risk assessment, the communication plan. Again, they have to be reviewed and updated at least annually. At minimum, they have to address the plans for the agency's patients during a natural or man-made disaster. That means individual plans for each patient included as part of the comprehensive patient assessment. Well, you guys have been doing that for several years, maybe many years. But we see a lot of non-compliance with that with the Florida agencies when it was just under ACA. So you just need to make sure your individual plans are really up to date all the time and compliant, and your staff know them, and your patients and caregivers and representatives know them. What are your procedures to inform state and local emergency preparedness officials about agency patients in need of evacuations from their residence at any time due to any emergency situation based on the patient's medical, psychiatric, and home environment? This is very important. Remember the hurricane and the SNF, where there was just an absolute disaster during the hurricane because there was a breakdown in communication between the SNF administrators and the EMS before many of the staff left. And so very important to have this in your policies and procedures, who you're going to inform, and then to test that in your drills. The procedures to follow up with on-duty staff and patients to determine services that are needed in event that there's an interruption in services. The agency has to inform state and local officials of any on-duty staff or patients you are unable to contact. And honestly, these COPs go so much with the full healthcare emergency preparedness COPs. They haven't changed them too much in our home health COPs. Well, when you're looking at a hospital, obviously calling on-duty staff is one thing, but in home health, you're going to be calling all your staff because, let's face it, you're using them all, every day, and it's not like we have 3 shifts around the clock. So you're going to be contacting your staff. Now, like Patty just went to Mexico, so you're not going to call her, but the rest of your staff you're going to call. You're going to call the patients, and those that you cannot contact, you have to notify the emergency preparedness officials. A system of medical documentation that preserves patient information, protects confidentiality, and secures and maintains the availability of records. This is not an easy one. This says that, yeah, you're on EMR, but if you can't access the EMR, how are you going to get information? It says, how are you going to do documentation when your EMR is down for a month? So, of course, that means paper forms. And at the same time, they're going to tell you all along the way that you have to communicate to the healthcare entities and officials that are taking over the care. But that protects confidentiality is that HIPAA is still in play. And so obviously there are some areas of conflict as you go through this, because how can you do this but also do this? Well, we're preparing in the best case scenario that we are protecting patient confidentiality, but then we may be involved in triaging them to get to other places to help them. The use of volunteers in an emergency or other emergency staffing strategies, including the process and role for integration of state or federally designated healthcare professionals to address surge needs during an emergency. So you can have in home health volunteers for emergency preparedness. A lot of agencies are confused about this and thinking that this is talking about hospice only. But no, for emergencies, you can have a list of volunteers who are going to be available to help out if there is an emergency and you do need help. That could be as simple as in one of our clients that I went to down in the boot heel of Missouri. If any of you is familiar with that, it's typically a boot heel. If you ever look at the state of Missouri, you'll know what I'm talking about. And they're, bordering on 4 states, and they're very southernmost region. It's a very odd split that was made when they made Missouri. And because there's cotton fields on either side, I didn't even know what they were when I was driving down there the first time. The second time I went down there, there was a blizzard, and it was a whiteout blizzard. I was stuck in the Drury Inn for the first 2 days instead of being at the agency, which was 30 minutes away because it's very rural. And so on the 3rd day, finally, it was good enough, but I wasn't going to be able to drive. But they had a list of volunteers, and these volunteers had very big 4-wheel drive pickups or SUVs, and they were picking up the staff and driving them to patients. And so this one was one of the nurses' husbands came and got me and drove me down to the agency. So that's what we're talking about here, so that you have accessibility to people that have resources that you guys may not have. As far as addressing the surge, you're probably going to be asked to have your clinicians help out in triage, command centers, hospitals, emergency rooms, etc., more than getting help from others to home health. So that's something that you're going to have to look at as well, that you're going to have these lists, but you're probably going to be asked to help. So C standard, the communication plan. The agency must develop and maintain an emergency preparedness communication plan that complies with federal, state, local laws, and guess what? It has to be reviewed and updated at least annually. All right. This is where we get down to real specifics. So we have the names and contact information for your staff, your contractors. Don't forget everything I've talked about in these COPs. Contractors are included in everything. And so your contractors, your patient physicians, and your volunteers. So again, this doesn't just stay with one person that's over emergency preparedness for your big system. That has to be with several people in your agency. And obviously it has to be updated a lot. And that's the hard part. And all of you that have been around long enough before the EMRs, so maybe you millennials just know the EMRs, but the rest of us, we used to do paper. We had manuals for everything, and they were a pain in the neck to update. Well, some of this stuff, that's what you're going to have to do. And then contact information for the following: federal, state, tribal, regional, local emergency preparedness staff. So of course, you know, you have to get on the horn with your emergency preparedness command center management team that is most local, and then go from there up. You don't want to start with FEMA and work down. Other sources of assistance that you may have that you're going to put there so that you have easy access in the event of an emergency. Primary and alternate means for communicating with your staff, federal, state, tribal, regional, local. So this is, you know, rough. This is, of course, everybody has cell phones today, so you think that's it. But if the cell towers are down, that doesn't help you at all. And then when everybody's battery runs dead, that doesn't help you at all. So maybe the landlines are working when the cell phones won't. When I was executive director at Unity Health Services, and my role was over the St. Louis area. So we had like 7 hospitals that were in this health system for St. Louis area, and each of those had an associated home health, hospice, private duty, DME, infusion. That was what I was over. Well, we would have, you know, our big management team sitting there figuring out what kind of alternate means. And we actually went to the extent, because we had such a huge region, we had very urban and we had very rural areas. And so our alternate means had to do with those two-way radios. I mean, that was the extent that we went to. You guys in Florida have had enough, you know, emergencies and disasters, man-made and natural, that it's not always a bad idea to think outside the box like that. And you'll get help from your local emergency management agencies to give you recommendations and suggestions. You have to have a method for sharing information and medical documentation for patients under your care as necessary with other healthcare providers to maintain continuity of care. That's what I was talking about. And now, I guess it's not here. Like I said, they're all fragmented. They jump around. But, okay, you have this method for sharing, but then later on, you'll see again more about confidentiality and HIPAA as well. So you have to share, but at the same time, you're working with your patients, their caregivers, their representatives to ensure that they are approving everything and that there is total confidentiality. Not always, it's kind of a rock and a hard place when you're in emergency and triaging, but this is our goal, so this is what we practice for. A means of providing information about the general condition and locations of the patients under the facility's care. And again, I guess this was it. It's as permitted under, and that's under the HIPAA regs. So the thing is that you have to be able to have enough of a, quote, report to be able to give to a triage center, to the 911 operator, whoever you're working with, to help get those patients evacuated and cared for that you can't reach, for example. A means of providing the information about the agency's needs and its ability to provide assistance to having to the authority having jurisdiction in the incident command center. So, you know, prior they said if you're a state and federal healthcare professional, but that's all of us. I mean, they're going to, and as you well know, I'm sure many of you clinicians and managers and office people on the line, non-clerical positions, helped a lot with things that we do in healthcare when your hurricanes came through, for example. And so that's what you have to plan in advance. You're going to be able to say to them, this is what we have in each of our disciplines, here's who's available, that type of thing. So you're going to basically be saying, here are the staff we couldn't reach, and here are all the staff we can, and these are the ones that are going to be able to assist. D, training and testing. So this is the biggie. You get all of the other standards put together, and I would imagine you have A and B, the plan and the policies and procedures, good. The communication plan, as I look at those are not very specified to the agencies and don't have everything in that they need to. Actually, let's jump back to the plan, because we've seen a lot of risk assessments that are not complete to what they need to be, particularly with the strategies to address them. Now we're into testing and training. So you have to develop and maintain an emergency preparedness training and testing program based on the emergency, the risk assessment, the policies and procedures, and the communication plan. You're looking at the whole situation and say, now, can we put this into practice? Before you have to, for real. Again, you have to review it and update it at least annually, and this is especially the part that I said, every time you do a drill, you're going to be, having to review it and update it, no doubt, because you're going to find things that you did wrong. It is not a bad idea to do more training or more testing than is even required, because weather situations, power outages, all kinds of things that happen. Your EMR going down for 2 days, your critical short staffing levels where you're going to have to triage patients to other agencies. Whatever the situation may be, if you enact your emergency plan for each of those and write those up, you should be doing all of that every time anything like that happens. And we have several a year, no matter where anybody lives. So if you do that, you're never behind on this, and you're always critiquing, and you're always well prepared, as well as being compliant. So for training, you have to initial training in emergency preparedness policies and procedures to all new and existing staff, contractors, volunteers. It's all the training can be consistent with their expected roles. You don't have to give the full to everyone. Although people, just human beings, need most of this. So don't forget, your existing staff have to have had this. So you're going to have to show training since November 15th, because this is all new, and you have to have it for your contractors. Then you have to provide it at least annually. You have to maintain documentation of the training. That sounds like a no-brainer. However, don't just hand me a sign-in sheet with a couple of names. You have to hand me a sign-in sheet with the, the written list of all of your staff and all of your contractors, and then show that they had this training and on what date. Then you have to have what that curriculum was that was with it, so that you can demonstrate that you have given what was supposed to be given. And then this demonstration of staff knowledge of emergency procedures. You're going to be giving them scenarios. You're going to be asking them questions right at the training and then subsequently, because when I'm a surveyor coming in, I'm going to ask them. And on the last couple of mock surveys that I have done, and I've done so many over this, we as a consulting firm have done probably more mock surveys in 2017 and so far in 2018 since we've been in business. I mean, we've exceeded every year of business, and it's because of these new COPs, the emergency plan, outcomes, on and on and on. And so, of course, we ask the staff a lot of questions like surveyors will ask them. And every time I have asked staff about how are they involved in the emergency preparedness program, what can they tell me about it, what have they done with it, I get blank looks, and that is really scary. And oh, by the way, I also get those blank looks when I ask them about CoP. So it does no good if your management can tell a surveyor all about everything and the staff can't. It also does you no good when you have a real emergency if the staff cannot say how their involvement is, what they have to do. Probably in an emergency, their autopilot clicks in, and if you've done enough training and testing, that's what's going to happen. Probably when I ask them the question, they just go blank. But keep in mind, when a surveyor asks the question, they can't just go blank. So this has to be familiar enough that they're involved enough that they know about it to say. 2 is testing. So you have to conduct exercises to test it at least annually, but of course it's going to be more than annually because you have to do the following. You have to participate. Oh, I'm sorry, I jumped ahead. You have to participate in a full-scale exercise that is community-based, or when a community-based exercise is not available, then individual facility-based. So as long as you're not behind, you should be able to jump into the full-scale community-based drills. There are very few across the country that don't do those. And so, you know, my goodness, I think as long as I've been a nurse, I've been involved in big drills that the hospitals have had every year. And whether I was playing the patient or when I was critical care director, I was over the ER triage. So you want to jump into those because that's the easiest for you then. You're involved in a big scenario that's put together where, let's say, your whole county or part of your county is really doing an actual test on what could occur with fake patients, real patients in your home health agency and in your hospitals, etc. If you can't get into one of those, then that's when you do the individual facility-based. But it has to be more than just what the agency the other day showed me, where, okay, it wasn't even a real tabletop as you get into the tabletop when we talk about that next, but they were saying that this was their drill. Well, it was just, you know, 3 of the top management saying, okay, we're going to say that we have a smallpox breakout and what we're going to do. Well, they're affiliated with public health, but goodness, is that a good scenario for a home health emergency testing plan? Not if that's the only one you're doing, and especially because they didn't contact any patients, any staff, or any emergency command centers. So you have to really do it. You're testing your system. If the agency experiences a natural or a man-made emergency that requires activation of the emergency plan, the agency is exempt from engaging in a community-based or individual facility-based full-scale exercise for 1 year following the onset. Now, we're going to get to the next page that says you have to do an additional testing, but this is what I was talking about. So if you join your county for the annual full-scale one, and then the next time, now I was going to say a tornado's coming, an ice storm's coming, a snowstorm's coming. Well, you lucky guys down there don't have that stuff, but sometimes you get tornadoes, and you definitely have hurricanes and floods and lots of other things. And so anytime anything like that occurs, put your emergency plan in place. You're doing it anyhow. You're triaging basically your patients that don't have to be seen over the next 3 days, and you're rearranging schedules, you're contacting your staff. Well, do the whole plan. Write that up, because then that counts. So these are the 2 best ones to do, is the community full scale and the actual that happens. And let's just pray that it's not a man-made, but the way it goes these days, you never know. All right, then you have to conduct an additional exercise that may include, but is not limited to, the following: a second full-scale exercise that is community-based or individual facility-based. So you can see right there, if you do what I say as a recommendation and do the full-scale community-based and an actual that comes up, then you're done, because you have to do that anyhow twice. But then a tabletop exercise could be the alternative. This is not as simple as sitting the 4 top guys down and saying, here's what we talked about for 2 hours. You have the group discussion led by a facilitator. It's already put together. It uses narrated, clinically relevant emergency scenario, a set of problem statements, directed messages, and questions prepared to or designed to challenge the emergency plan. So what you do is you have a group of stakeholders, so that's every discipline, every position, and you're sitting around a room for at least half a day, and you're walking through exactly as if you were doing that community or individually facility-based drill, and you have to have it written up in that manner. All right, so this is the toughest part that we see a lot of agencies are not compliant with. Either they didn't do near enough or they didn't do them. So that's what you're going to really want to make sure that you get on. Then you have to analyze. I've been talking about critiquing. So you have to analyze your response. And so say, okay, here was our drill that we did with the community. And well, we couldn't get in touch with these 5 staff and these 5 patients, but we didn't also get in touch with the emergency management command center, and we didn't keep following up till we got through to them. Very important. That's similar to that long-term care facility in Florida that a disaster happened because of a breakdown like that. That wasn't the specific one. If you were in the area, it wasn't the specific scenario. It's just an example like that you have to make sure things like that don't break down. So in your drills, they will all the time, and that's the whole purpose of doing the drills, so that you are very prepared when something real happens. So you're going to have a lot of documentation. You're going to have a meeting to go through and say, how did we do? Here was where we had misses, near misses. Here's where we have recommendations. And now what are we going to do to correct all that? Well, that is updating your plan then. So hopefully that makes sense, how you pull this all completely together through the critique. When I was in the meeting on Monday with this agency, and the emergency preparedness director gave me a manila folder that had a couple of pieces of paper in showing what they did for the home health emergency preparedness, I knew that we were in trouble. So then she went and got the big manual that they have for their whole system, but I kept looking across at the home health director and the home health administrator, and they weren't involved in any of it. They didn't do any of this. So it's going to talk about an integrated healthcare system in a minute, and that's what's so key. Your home health for your certified number has to do everything I just talked about. All right, this is it, the good segue, E, integrated healthcare systems. So if you are part of a healthcare system consisting of multiple separately certified healthcare facilities, and you choose to have a unified and integrated emergency preparedness program, that's a good thing. You can be part of that, but you have to do the following. You have to demonstrate that each separately certified facility within the system actively participated in the development of the emergency preparedness program. So I told you how the administrator and director weren't at all involved in the development or what they were planning. They have to be developed and maintained in a manner that takes into account each separately certified facility's unique circumstances, patient populations, and services offered. The home health agency was not worried as much about a smallpox outbreak as it was about a flu outbreak. And so those are the types of things that our patient population in home health are going to be very different than a hospital, a rehab, a SNF, a public health, etc. And it's not to say that something that happens in one doesn't matter to the other. Of course, I'm not saying that a smallpox outbreak is not horrible. It is, and it will affect all of us. But this is taking into account what are your likely emergencies that will come up in your home health agency for your patient population, and how will it affect your patient population? If it affects your patient population very minimally, you're going to want to then do a different individual facility-based drill instead of doing that systems drill, for example. So for that agency, we set up that now they have one scheduled, and it's going to be a weather-related one, because that day I was out there doing home visits as a mock survey, and it was really bad because we had an ice storm over the weekend where I live at Lake of the Ozarks. This agency's like, I'm like 4 hours to St. Louis. They're 2 hours, away from St. Louis. So I drive to them and do an on-site mock survey. Well, it was kind of hit and miss if we were going to have to postpone because of the ice storm, but it looked like the temperature was supposed to get up, and so we decided, okay. So I went in. Well, yeah, the main roads are okay, and a lot of the side roads were okay. I saw 6 patients that day. 4 of the 6 patients, it was hazardous to get in and out of their house. I was skidding all over the place. We were skating on sheets of ice to get up driveways, to get on walkways, to get up steps, and even on the porches. Well, I said to the director, she was so worried about my safety, and I was too. But I said to her, the thing is that these patients have to get out in emergencies, to doctor's appointments. In fact, we were at the one patient's house, and they were the wife and he were talking about having to go out to the doctor, so they didn't have a lot more time. And so as we left, I said to the director, how are they going to get out? This is a sheet of ice. So you have to come up with plans. Now, I know you guys don't deal with that, but you can put that to so many scenarios as things just happen on a day-by-day basis. So I said, we have to do an action plan for this. It was very simple. Every place that had been salted, the ice had melted. And so have somebody from the agency go around, or have all the field staff as they hit the patient's house and salt for them. So these are the kind of things you're looking at with home health that no other healthcare entity would think of. So that's what we're talking about, your specific facilities, unique circumstances, and patient populations. Okay, so now you have to say, you're using this unified and integrated emergency preparedness plan. Are you capable of complying with that? Well, with that smallpox scenario, they were not. There was nothing that they were doing with it. So now it has to meet all these. So you have to still do that risk assessment, all hazards approach. It can be a full one for the integrated health system, but then you still have to have your own individual facility-based risk assessment. So if you're within a health system, of course, that scenario I gave you about going to patients' homes with the ice would apply. It would also apply if you are in an office that floods all the time. That type of thing would apply. And your patient population. And then you have to meet all the requirements of this COP. All right. So now that's the end of the COP. What we do is we put some of CMS's resources that we think are good, and then I'll give you some of the links that can help you with your emergency preparedness program to beef it up, to understand it. And these next slides are just a few of the examples we took from that. Well, obviously, I've talked about this a lot throughout, that I'm a believer in having a great emergency preparedness plan, not just to do well on survey, but to help you for horrible disasters that happened like yesterday. Think of how many fatalities and injuries there had been if that school wasn't very well prepared, and their teachers, my goodness, I was hearing a teacher talk about all they did right away, and I was thinking, man, how are they so calm and cool to think of all those things to do? Well, they test it all the time, and he was saying how they just had tested it again. So it is crucial to be able to, and then relating it more to healthcare. Think of the SNF last year with the patients that were there with no help. So hazard identification, you have to make every effort to include any potential hazard that affects your facility directly and indirectly. So maybe you can't get your medical supplies, maybe your infusion company, maybe you do a lot of IVs and you're basically the nurse for their IV company, although it's a separately certified home health agency and you have those patients on as patients. And so if you can't get supplies and drugs from them, what are you going to do? What is your patient going to do? So, and of course, utilities. Staffing is huge because you may have a lot of staff that live in one territory and the other territory is hit, and now you are up the creek because you have no staff. So those are all the types of things in hazard identification. And you can see why doing a 1-hour meeting with the top bosses isn't going to cut it. You have to have a team of all of your stakeholders in talking and going through all this at least a half a day several times. This isn't just something that it's kind of like CoP. You can't expect to say to me, do my CoP for the last 3 years in the next week. It's that same way. You have to have this ongoing. You have to have a lot of people involved. It does take some work, but don't just get mad and say, how are we ever supposed to do this? Think of this one as I try to say CoP for you, it's going to prevent crises, and that's a good thing. Well, this is going to help you eliminate or at least be prepared for a disaster and, if necessary, a new normal. So your hazard mitigation, that is, what can we do in preparation to eliminate or reduce the probability of the event, or when the event happens, how can we reduce its severity or consequences? And that's prior to, during, and after an emergency. And residences, because this is off of CMS for all 17 healthcare facilities, but you need to do that mitigation process for both your patients and staff. You're going to say, how are you going to educate your staff and address care for patients in the likelihood? So lots of staff education and lots of practice is what's going to help this. So the preparedness plan, this gives you some tips on how you're going to do that. I think I've talked about most of this. The response, so immediately before or for an impending threat, a hurricane's coming tomorrow, during and after, to address both immediate and short-term effects. Then the recovery is where, what do you do during and after to have a new normal? Well, that poor agency had to move 3 times, and now the 3rd time she's in a permanent location. Okay, so here are some of the links that we liked off of the CMS site. There's many, many resources out there. We just wanted to put some from CMS since they're the guys that wrote the COPs and will be surveying us. So there's the surveyor guidance if you don't have that, and all hazards FAQ and checklists. And then when you get in there, there's lots of other things that you can download. All right. So 484-100 is the compliance, it's the catch-all, federal, state, local laws and regulations, health and safety to patients. There's less that we have to put in there today. And when I say when we have to put in there, I'm talking as a surveyor. That was always a catch-all. That was where infection control went. Well, now we have lots of specifics for infection control, but a lot of our catch-alls that went there. Our COPs are much more specific, so I don't suspect this will be used a lot anymore as that part. But if you are not following a state law, that's where this will go. All right. Well, first of all, of course, you have to be applicable. I mean, you have to be in compliance with all applicable laws and have to be licensed. Disclosure of ownership and management, this is when things change that you have to redo an 855 for a chow or any change of ownership, etc. To be, you have to be licensed in your state. You have to be. If there are a few states, in fact, Missouri is one of the few states that They don't do a separate home health license. They do for hospice, but for home health, you just have to be Medicare certified. So that's what makes it hard for private duty agencies in Missouri. So the states that aren't licensed, that's not always a good thing. The lab services B is the one that has the one change. It's probably not a big deal, but gosh, in Florida it may be. There has been some issues with this in areas of Florida. So the biggest thing is if you are helping a patient to self-administer a test, let's say they're having a hypoglycemic attack and they can't do their blood sugar because they're shaking too bad and their caregiver isn't there. You're with them. And so you pull out your blood glucose monitor that your agency has and you use it. We're not supposed to do that. We're supposed to use, I shouldn't say supposed to, this says you may not substitute. You have to use that patient's equipment. And that is just because what if the quality controls are off, and what if you get a totally different reading on yours than the patient's equipment? You want to have what the patient's been doing all along, so you can't do that. This goes into a lot of if you're CLIA. As I was researching it to do classes on the updated COPs, when you read the whole thing, you get into not only CLIAs, but cows. I've never heard of a cow in all my years, and it wasn't new. And now I can't remember again what it stands for. It might be change of waiver. I'm not quite sure. But most agencies have a CLIA. Some agencies choose not to get a CLIA. I never recommend that, because what about emergencies? And of course, if you're doing ProTime machines, you have to have a CLIA. And so if you don't have a CLIA, there is that other option that's called a CAL. It's so easy to get a CLIA. I would always recommend that. So in conjunction with not substituting your own equipment when you're helping a patient self-administer, you can use your own equipment, your agency's equipment, for a short defined period of time for when the patient hasn't gotten their own equipment. As an example, they're a new diabetic or the doc just ordered it. And so that's when you would use your agencies, but you're expected to get this equipment for that patient as soon as possible. So it does come up to me a lot to say, are you talking about ProTime machines? Well, at this point in time, I'm not. Maybe sometime in the long future, those will come down in price and those will be typical for patients to have. So what I see this talking about is definitely the blood glucose monitors that you can usually get free for your patients. It's that then you have to, get them in touch with a supply company or a pharmacy to have it set up through Medicare for the strips. But we are expected to help that patient obtain it. They want us to help the patients get their own equipment, of course, because then we're helping them for when we discharge them. But, you want to make sure that they have it in an emergency, and you may have some in your office for emergency, but you may not have it there. Now, this is talking about if a patient doesn't get their own equipment. And so basically, they're refusing to obtain it for some reason, some barrier or another. If it's a patient on Medicare, well, and I would think any payer source, you can't go daily or multiple times daily for a long period of time to do blood glucose checks because the patient isn't getting one. And so that's a situation you would not keep them on. You, of course, wouldn't discharge them immediately. You would go through that whole process, but ultimately, if they're refusing, then you would discharge the patient because the payment source will no longer pay, because that's not approved. This is where it, talks about CLIA, and, I imagine most of you have a CLIA waiver, and if you don't, you can read through the final rule responses a lot and the full COP on lab, and my recommendation is to get one. 484.110 is clinical records. Last condition, we're almost done, but it does have a lot of important stuff. So, of course, you have to maintain a record for everybody. It has to be accurate. That sounds like a no-brainer, but how often are our clinical records not real accurate? It has to adhere to current clinical record documentation standards of practice, be available to the physicians issuing orders and to the appropriate home health staff. And of course, it may be maintained electronically. 5 standards: contents, authentication, retention, protection, and retrieval. So your record must include a current comprehensive assessment, including all assessments from the most recent home health admission, clinical notes, plans of care, physician orders, all interventions, et cetera, et cetera. How do you like this one? Goals and patient's plan of care and the patient's progress towards goals. I can't talk. It's good. We're almost done. Goals and the patient's plans of care and the patient's progress toward achieving them. So that progress towards goals is said many, many times in our COPs. You have to have the contact information for the patient's representative, if any, and the patient's primary caregivers. You also have to have the contact information in the clinical record of the primary care practitioner or other healthcare professional who will be responsible for providing care and services to the patient after discharge from the agency. And you saw that earlier a lot of times about coordinating with the person after you discharge. All right, so this is new. A completed discharge summary that is sent to the primary care practitioner or other healthcare professional who will be responsible for providing care and services to the patient after discharge from the agency, if any, within 5 business days of the patient's discharge. So keep in mind here, this isn't just to your doc who's signing your 485, your plan of care doc. This is who's taking care of them after. So maybe an orthopod is doing your plan of care 485, but now the PCP is going to follow up after you discharge them. So you have to know that. And you have to get there 5 business days of the patient's discharge. Then you have a completed transfer summary that's sent within 2 business days of a planned transfer, if the patient's care will be immediately continued in a healthcare facility. Now, it's good because they put this next one because so often we aren't aware. So they are saying, or a completed transfer summary that is sent within 2 business days of becoming aware of a planned transfer, if the patient's still receiving care in that healthcare facility at the time when you become aware. So you're going to have a tickler for these time frames, because I know lots of agencies are late on their discharges and transfer documentation. So that, especially that 5 business days of the patient's discharge, that you're going to have to look at your process flow for your discharges and make sure that that is really cleaned up and you can get that out in 5 business days. Authentication, this has to do, I have more stuff bolded, but the big thing is all entries must be legible, clear, complete, appropriately authenticated, dated, and timed. So this is where it says, people are always saying to me, well, where does it say that every entry in a chart has to be timed? Right here. It's under authentication in the B standard of clinical records condition. Everything has to be timed. That next thing, and that is good since we're talking to Florida, because I have seen this in Florida. For some reason, there are a lot of agencies that weren't putting their occupation, their title, with the signature on entries. So that has to be there. Whoops, I'm sorry, my phone just fell down. This is where it explains that timed means the actual time that the event occurred and not when the event was documented. And this applies, date and time requirement applies to all entries in the record. It's so funny, I teach that all the time, and then I have agencies constantly saying, well, do you mean that this piece of paper has to be timed? Does this one have to be timed? So here you go, as it says it right there. Of course, they want it to be able to tell the linear story of the course of care. They don't want it to be disjointed, possible occurrence for medical errors. Electronic signatures, this just says that it has to have a unique identifier and have to have your title in there as well. This is where it's saying, and my recommendation is the same as the final rule, is it's not a good idea to shred original signed paper documents once you scan them in. I have seen a big error where a clerical made an error and scanned in Medicare secondary screenings twice, and she batched them every week to scan all the documents in. So this was for about 20 patients. She scanned all of those in, and then she shreds everything. Well, how it got discovered was I was doing a mock survey, and thank goodness it was a mock survey and not a real survey, and I wasn't finding copies of the home, well, I was seeing copies of the consent in the home folder on about half the patients I visited. On the other half, there weren't signatures, the financial part wasn't filled in, whatever. There were a lot of problems with their home folder copies of the consent. So when I went back in, I asked for the paper charts so that I could, well, no, I said I need to look at the consents, and the director said they're in the EMR under the scanned documents. Well, I wasn't finding them on these patients that I'm talking about, and so then they had to go get the paper chart, and the director comes back and says, they're not in the paper chart, so we're concerned, but we're looking. And as it came out, they figured out that in all of those charts, it was the only time that the Medicare secondary was in there twice, and there was no consent. So they had shredded the original copies of consents just because of a very simple error. So keep that in mind. This isn't in the law, it's in the final rule of response, but it's a good recommendation. It is in our Federal Register, but it's the responses. Your clinical records have to be maintained for 5 years after discharge of the patient. Now, this is unless state law stipulates longer. Most of the states do stipulate 7, and they have criteria for peds. So, you know, you want to make sure of that before you just do the 5 years. I honestly, we have a lot of manuals we've done for Florida, and we have clients there, but I honestly can't remember if Florida has more than that. And the agency's policies must provide for retention of clinical records even if it discontinues operation. When an agency discontinues operation, they need to inform the state agency where the clinical records will be maintained. That just talks more about retention, and this is about confidentiality and HIPAA. This is the very last standard of the very last condition, and it's a very important one for you to have as knowledge and a process and a time frame in place. When a patient asks for their record, and they can get it hard copy or electronic form, it has to first of all be free of charge. It has to be available at the next home visit or within 4 business days, whichever comes first. Probably if you have an active patient that asks, that next home visit is going to be quicker than 4 business days. So you're going to have to really hustle for your active patients to get that chart free of charge before your next home visit. If they're a discharged patient, you can't charge anymore. Agencies, for as long as I can remember, have charged and typically have said 15 or 30 days. Now it's free and it's within 4 business days. And I get asked so many questions about this too, and all I can refer people back to is read this sentence. This is all I can tell you because I get so many scenarios put to me, or agencies will tell me how unrealistic this is, and all I can do is say, here's what the law says. Now, when our draft or when our final interpretive guidelines come out, if something, you know, says something different, but I doubt it on this because it's the patient's right to have their record. You guys made it. So I want you to all sit. That's not what I look like, but I certainly meditate like that. And so that is one of my meditation pictures. And so that's the most important thing. Keep calm and take a deep breath. If you're scattered, running around like chickens without their heads, preparing for a survey that's in a month, well, that doesn't do you any good. So break down things you know you're not compliant into little sections, have task forces. You little guys that are saying she doesn't understand, I do understand. You have field staff, you have office staff, you have a governing body. You need to get everybody involved because everybody has to pitch in no matter what your size, because there's a lot to do. It's hard enough, even if you have been preparing for the past year, just to have everything implemented and audit that everything is in place and try to figure out the meaning of a lot of these things when we don't have final clarification. So, you know, you just want to try to keep a very structured approach, breaking each little section then into action plans and having different people work on different things. And that's the best that you can do. I see too much panic out there. And you know, sometimes that reflects then on us, because if I get 10 emails and calls in a day where they're panicking and they need help yesterday, I'm then trying to get my staff that are available, and, you know, our plates are so overflowing because so many agencies are in panic mode. And oftentimes as we get working with them, we see, you know, you don't have to be in panic mode. You just have to do these 3 things. So that is my best recommendation to you. And I want to say thank you so much for joining me on this, me and HCAP, for this 4-part series. And I certainly hope that I was able to help you some. You have my email here, and we do have time for questions now, but if you think of questions afterwards as well, you are free to email me. If an agency has several branches which are individually accredited, would they be considered a separately certified facility? Well, the first answer to that is, are you Medicare certified? If your locations are Medicare certified, then they have to have, you know, the full certified program. Your accreditation is different than certified, so you'll have to make sure you know if your locations are certified or separately, or if they are a branch of a parent. As far as the accreditation, we have 3 accrediting bodies, but they're all pretty much following the same thing. You have to make sure, though, that I'm not forgetting to tell you something that isn't in your accrediting standards, because, you know, as impossible as it may be for you to believe, it's hard for me to keep this all in my head anymore, but they all pretty much follow the COPs. It would be that same way where, oh my, the question just disappeared. It would be the same thing that I was talking about, in that you would have to have it, whether it is a separate facility certification, accreditation certification, or if it is a parent and a branch, you still have to have it very specified to separate locations, because those locations are there even if they are a branch, because probably they're in a different geographic territory, so that means their emergencies may be different. Their staff are different. Maybe they have a different patient population. Maybe they get a lot more wounds out of that area. So honestly, you have to know if it is a separate certified, if it is a branch of a parent, and how you are accredited, what they're looking at. But it doesn't really matter, because the company can do that overall integrated. That's fine. But each location has to drill it down. Their risk assessment and their drills and everything they're doing has to be specific to them. Do you need a separate policy for each disaster you identify on your risk assessment, such as hurricane, ice storm, etc.? If so, are there policies that can be bought? Okay, you don't have to have a separate policy, but you have to take that risk assessment you're only going to put things that apply to you. So as I'll jump to, can you buy that? Well, this is not me selling to you, but my company, as well as many, many other companies, do have emergency preparedness, policies and procedures and plans that they are selling. So yes, you can. Now, for instance, mine is going to have what you have there, hurricane and ice storm. Now, I don't think those two things will happen too often in one area, although in Jacksonville you did have snow this year as well, so you never know. But hopefully here at Lake of the Ozarks, I'm not going to have a hurricane, but I'm going to have ice storms and I'm going to have tornadoes. And so I will probably take out the hurricane on mine, and I will take out anything that doesn't apply. We just talked to an El Paso agency that we've had on service forever and ever, and they are right there at that big canal at the Rio Grande that every time I was there, that's been dry, amazingly. Well, anyhow, I'm thinking flood because they're right there. But they said, no, sandstorm. So that's what you have to do. Now, it doesn't need a policy, but you're identifying in your risk assessment that you're going to have hurricanes, no question about it. And then you're going to have your strategies there that are associated with hurricanes. Those strategies then lead to your testing and your training and your drills. Let me, give me a little bit in between because I'm trying to scroll down and then I am trying to make each one bigger. What documentation is needed for use of volunteers? Would they need to sign a private agreement, for instance? I honestly can't tell you that I know that. I haven't thought through that. What my best answer would be is, yeah, you're going to want to have an agreement in place with them, not a subcontract like you do for your contractors, but something that does say that if you're ever representing your agency, that they have to have confidentiality and they have to follow only the tasks and duties to which they were trained and, will be asked to do. I would think that that would be the best to do. I have not seen any home health agencies have volunteers for emergency preparedness. That, of course, does not mean that there aren't a lot of agencies out there that have done it, but it's actually a good question. I don't know, Monica, maybe that's one for HCAP. If maybe you are, there's several consultant attorneys that I'm thinking of, or maybe even Bill Dombey would know the answer to that. I don't know if that's something that you could get, Monica.
Sure, we can investigate and get back to everybody.
Okay, and if you need my help with it, just let me know. What if a patient is discharged without having the need to follow a physician? Where would you submit a discharge summary? Well, the thing is that they are under your care. They're, in the care of a physician. So for sure, I would send it to your 485, your plan of care signing doc, the doc that is over home care. This condition is more related to who's following them after, but with all the coordination, case management, continuum of care we have to do with the plan of care signing doc that's, taking care of the patient in home care, specifically in that case, I would send it to them. No, that is not in the reg. That's my recommendation. Do we have to wait for the patient to sign to get a copy of their records? Well, yeah, I would have them sign whatever release you have. There may be a HIPAA form for that, or it may just be your form for release of records. So definitely go through that process. However, you're going to have to do it very fast. And that's the biggest question I'm always asked is, well, goodness, we have a process. It has to go through this department and this department and this department. Well, you have to do it before the next visit now or before 4 business days afterwards. So, I don't see any leeway in that to be compliant. And so that's an area that probably your process has to change. because it always has been a slow process before. I'm not aware. I really should have asked before now, because I am curious, do the hospitals have that same thing? Because their process is very long. However, there's more portals these days that I can see my records at Lake Regional. The second I leave the doctor's office, I get back and I have emails that my portal's been updated. We don't have that in home health, and so it is going to be a process where you're going to have to really hurry. Yes, both are Medicare certified separately. That's for back to the integrated emergency preparedness plan. Okay, so if my organization is called XYZ Home Health Agency, and I have 2 separately certified facilities, I can still, as XYZ, have those administrators, directors, and various stakeholders involved to start the overall plan. And that can be our XYZ Home Care Agency emergency preparedness program. It doesn't stop there. Then certified agency A gets it, certified agency B gets it, and now they do all the other things to customize to their agencies. If it makes sense to do a drill together, which no doubt it would, then we can do the drill together. But you are each having documentation of calling your own staff, your own patients, the command center, and then writing it all up and doing a critique and all of that. We can then, at my, corporate office at XYZ, I can have it all right there. But each of you need to also have it in your offices so that it's more than one person accessible, and it's very individualized like that.
I'll turn it over to you for your final thoughts.
Great, great. So like I said, email me if you have other questions. A lot of times, as agencies are implementing, that's when the questions come up. And just keep in mind, I try to teach you black and white as much as I can, and I also tell you the things that I don't know or that are still clear as mud, and that's where the entire industry is. So good luck to you, and hopefully you don't have your survey for another year, so you have this year to really get into compliance. But I know a lot of agencies are coming up, so thanks for joining me.
And HCAS wants to extend a big thank you to you, Sharon, and to 5-Star Healthcare Consultants. And I'd like to extend a thank you to all of you for taking time to join us for today and for supporting this educational offering. We hope you found today's presentation and this whole series worthwhile, and you tell your friends about it. Thanks. Bye. Have a great day.